So, this is a much different lecture than I normally give because I kind of summarize all that's known about COVID or about hypertension or this and that and the other, and make it without much data except the essential ones. The issue with COVID and what to do with obstetrical patients who've had COVID is, it's all over the place. So, and we don't have any clear-cut data to say what we should do. So I basically wanted to just share you a meta-analysis that was done last year. And most of these things have continued to come out in more individual studies. To the right, you have your forest plot, and there's a dotted line in the center. And if the square or the diamond goes to the right, it means that preeclampsia is increased in post-COVID patients. And to the left, it's decreased in post-COVID patients. So this is basically analysis of individuals who've had COVID versus the ones who have not had COVID. And so there appears to be an increased risk. Next slide. Now, some studies break it down to severe COVID versus mild COVID, COVID versus no COVID, symptomatic COVID versus asymptomatic COVID. But I'm going to share with you how the meta-analysis shared it. And you can see that there's an increased risk of preeclampsia when the disease is more severe than mild. Next slide. The other issue is preterm birth. Okay, so there is, again, most studies show it's to the right of the dotted line. Most studies show that there is an increased risk of preterm birth, and the correlation of all the studies represented in the diamond show that there's an increased risk. Next slide. Again, this looks at symptomatic and asymptomatic COVID, and we find the same thing. Next slide, please. And then we find the same thing in severe and mild disease. Preterm labor is increased. Now, everybody knows, for example, if you're obese, you have chronic hypertension, you had a prior history of preeclampsia, you have renal disease, everybody knows that you're at increased risk for preeclampsia. Same thing with preterm birth. Most studies actually excluded multiples, and so only the singletons were reported. And preterm birth, there's multiple causes for that. For example, if maternal health is deteriorating and we think we're going to lose mom and potentially baby too, sometimes we intervene on behalf of the baby. Sometimes it's spontaneous preterm birth. The mom goes into labor, and it could be from COVID, or it could just be from being really sick, because people with pilo and sepsis, a lot of them go into preterm labor just from the inflammatory response in their system. And so most studies can control for what we call confounding variables, but the meta-analysis is only as good as the studies it include, and many of these studies were not controlled for confounders. So just understand that and know that that's why we can't take some of this information for the gospel. Next slide, please. Now, one of the first things reported out from Europe was that there was an increased risk of stillbirth. They actually quoted the stillbirth rate as 1 in 100. And therefore, they have made people, made literally the world obstetricians aware of this. So in this study, again, there appears to be an increased risk of a stillbirth. And I will tell you that everything I've looked at, stillbirth is still a risk, okay? And the stillbirth rate is double, like on the CDC website, it is double what it is in the average population, which is significant. Next slide, please. So why does the stillbirth occur, and why is preterm birth and preeclampsia worse? Well, preeclampsia and preterm birth are associated with an inflammatory response, and there's a tremendous inflammatory response with COVID, even if you just have mild COVID. And granted, pregnancy might be blunted, the inflammatory response might be blunted just a little bit, but they are still inflammatory response. I also think that the inflammation in the placenta actually helps release factors like S-FLIT and PLGF and VEGF that actually makes it more, makes women more susceptible to preeclampsia and to preterm birth. Swartz, who is at Emory, actually got literally collected placentas from stillbirths, and they reported about 70 stillbirths, and over 75% of the placentas had fibrin depositions in it. There were the death of the cells in the trophoblast, and there was a specific type of velitis called chronic histiocytic intervillositis that was present in over 75% of the patient's placenta with a stillbirth. So fibrin deposition actually, it's kind of like a blood clot. It cuts off that area of the placenta to oxygen and stuff. And the trophoblast is the interface with the maternal system, okay, that transports the nutrients to the fetus, okay? And the chronic histiocytic velitis is basically, it's an infiltration of histocytes into the placenta, which is very rare. So they looked at the baby the stillbirths, and it doesn't appear that the baby has the same reaction that the placenta has. It appears to be confined to the placenta, but we all know that the placenta is what supports the pregnancy. So next slide. Then the question, and this is entirely based on expert opinion, okay, because we do not know exactly what to do, okay. The one, we are doing antenatal testing, and I think most people in the country are on COVID related patients or COVID patients who have recovered from COVID. So the question we debate is, when should we start antenatal testing? And the week that they get COVID, they're at increased risk of stillbirth. And so I personally recommend it from the time they recover until they deliver. Okay. And you can do that once a week. You don't necessarily have to do it twice a week, but I still think it's important to do it. Some of my partners would argue that it's only 32 weeks we should start. Others would say we just need to do 36 weeks. But because of the findings in the placenta, which can be acute, I personally think we should do antenatal testing after the patient gets out of the hospital or recovers from COVID. With this, I will tell you that there hasn't been an increased risk of a C-section nor interpartum fetal distress with patients who have recovered from COVID. And so I don't counsel the patient that there are increased risk for fetal distress in labor. Now, the growth ultrasound, like if somebody gets a COVID at 22, 24 weeks, 20 weeks, 18 weeks, we do a growth scan like at 28 to 32 weeks, because the placenta is most of the time, placenta insufficiency is what affects the growth. And therefore, the growth ultrasound is important. I don't think we should be doing them every 3 weeks or every 4 weeks, unless we find growth restriction early. Now, we are delivering these individuals by 39 to 40 weeks. We're not delivering them before 39 weeks unless there's another indication like preeclampsia or abnormal antenatal testing. But we are trying to get them delivered by 40 weeks. Now, I don't know if y'all know this, but when I was in California, I backed up a freestanding birth center, and I'm actually the physician leader for the Charleston birthplace in Charleston. And so the question I had to myself is, should I allow patients who have had COVID and have recovered, should they still be allowed to deliver in a birth center? And after I've read, I still don't think there's an increased incidence of fetal distress intrapartum. And most birth centers actually do intermittent monitoring. So I have allowed the patients to stay in the birth center. I've not made them come to the hospital. Now, every one of the placentas where there was a stillbirth, they had not been vaccinated, not even one. Okay. And the only way we have to prevent the massive inflammatory response is to vaccinate. Some of the antiretrovirals may help the inflammatory response, but the best prevention is to vaccinate. And can you go back one slide, Rachel? So the other thing I will tell you on this one, I do tell the patients about fetal kid counts, and I recommend they do fetal kid counts at least once a day to make sure their baby's moving. And if it's not, then if they don't get 10 kicks in 1 hour, I recommend that they come to the hospital. Now go to vaccination. This is the issue. You know, so many people come into my office and they say, "Oh, Dr. Johnson, I'm just worried about what that vaccination is going to do to my baby." Well, I tell them that I have not read any reports, including the CDC tracking system that looks at vaccination, that there is an increased risk of adverse pregnancy outcomes. But I say, sit down and listen to what happens when you get COVID in pregnancy. And therefore, I tell them we do know pretty much that there's an increased risk of stillbirth, increased risk of preterm labor and preeclampsia. And just in the last week or so, Chris Zahn, who is a public relation person for ACOG, he's a physician, both he and his wife, and he basically said that he still does not think that there's enough data to say this, and that may be true, but I had rather err on the side of caution than to try to get myself out of trouble. Now, I do have a question in the chat box. This says, when would you start antenatal testing